Hello, and welcome to Talking General Practice, the podcast from GP Online. I'm Emma Bauer, the editor of GP Online. Today on the podcast, I'm talking to Tara Humphrey, who's the founder and CEO of THC Primary Care, which provides management support and training to primary care networks across England. She's also the host of the Business of Healthcare podcast. In this conversation, I talk to Tara about all things primary care networks. We discuss what makes a successful network, some of the challenges networks have had to overcome, and the positive side of the additional roles reimbursement scheme. We also talk about how the 2024-25 GP contract could affect PCNs, why financially secure GP practices will be crucial to the success of networks, and I asked Tara whether she thinks networks are here to stay. Before we move on, just to let you know that MIMS Learning Live London takes place on the 7th of June at the Business Design Centre in Islington. Organised by our colleagues on MIMS Learning, the event is free to attend for healthcare professionals working in primary care. This year's programme features streams across 4 key therapy areas: dermatology, women's health, respiratory and cardiovascular renal metabolic medicine, with expert speakers who'll provide you with actionable insights for immediate application in your practice. There'll be plenty of opportunities to ask questions and network with colleagues, and the event provides 5 hours of CPD. You can register for your free place at mimslearninglive.com. I'm really pleased to be joined on the podcast now by Tara Humphrey, who is the founder and CEO of THC Primary Care, which provides management support and training to primary care networks across England. Tara has over 20 years' experience in business development and operations management in the public and private sector, and has an MBA in leadership and management in healthcare. Through her work with over 120 PCNs, as well as training hubs in South London, Kent, Surrey and Sussex, she's gained really valuable insight into what makes a successful PCN and how networks can overcome some of the key challenges they face. Tara also hosts the Business of Healthcare podcast, which talks to managers, doctors, patients and others from the healthcare sector, and covers leadership, management and patient stories. Thank you so much for coming on the podcast, Tara.
Thank you so much for asking me.
We're going to talk about primary care networks today and what could lie ahead for them. But first of all, can you tell us a little bit about what it is you do now and how you work with PCNs?
So we provide interim management for primary care networks. So we typically work with networks that are struggling to recruit a manager, or they may have had high turnover in that management position. So we will go in for a defined period of time, get a bit of lay of the land, and just start to make improvements. And then over time, we replace ourselves and recruit a permanent member of the team. We also provide leadership training. So someone said to me once, right, where do I find a Tara? And I said, I can train them. It's kind of hard work, but it can be trained. So we created an induction program, and then we teamed up with Ben Gowland and Andy and Gandhi from EGP Learning, and we've got our PCN Plus leadership course, and just also do facilitation. So typically we just work with networks that probably a little bit struggling and just want a bit of direction and some hands-on support, and we do that virtually and in person.
Is the management side of it one of the areas where you find that networks find it a bit more tricky?
It just is really varied, but the networks that we work with are looking for more structure, more organisation, better communication. They want to know what is happening and why they're doing it. But that's, to me, like basic management and administration, but it's really, really important. And I think most practices have a practice manager. That role is so, so important. And I think for the networks where practice managers are at capacity and don't have the capacity to run their practice and the whole network, having a manager and administration in place is really key to delivering clinical services at a hub-based level, definitely.
One of the things that I think has come out time and time again, and certainly from work that the King's Fund have done, is it was quite a big ask to expect practices to set up these networks. Really, they've not had potentially the kind of support they needed in terms of delivering such a big organisational change. Is that something that you would say is true from your experience?
Yeah, I think it's fair. I think networks kind of came together just when COVID hit.
Well, yes, yeah.
Sometimes when you know that you've got a focus, even though it was a terrible focus in many respects, but it did kind of rally the troops. But it also highlighted where those relationships weren't there, and the multiple meetings and people not being clear on what is happening and then that causing tension. So we've just been on a hamster wheel, and it's really hard to stop and reflect and say, okay, well, what is working well? What do each of the practices, what are their strengths? What is our strength collectively as a network? And how are we going to make this happen? And there's lots of roles that, like, I obviously champion the primary care network manager. I definitely champion, when nobody ever talks about, like, primary care network administrators and coordinators. Now we've got the digital and transformation lead, and we've got the clinical director, you've got clinical lead, you've got practice management. They need support and structure. So they're not constantly repeating themselves. They're not rolling out services or rolling out changes where they haven't engaged people. They don't fully understand, like the mechanics of certain things. So support is there. So, there's lots of organisations, there's GPIL and GPIP, that do provide support, often for free. And Kent and Medway, where I'm based, have been rolling out a quality improvement programme for years. And that's like integrated now across health and social care, and can't give these places away. I think that people always debate that there's not support, but there are networks that have gone to their university and say, this is our challenge, this is our problem, can we work with you? There are course providers, and even just other seed clinical directors and other managers coming together, like peer support. You do have to probably proactively find it, but I do think there is support there.
It's quite difficult though, isn't it? Because obviously since COVID, there's been an absolute explosion in the kind of level of demand that practices are having to deal with. So for lots of GPs, not all, primary care networks can seem like an additional thing that they have to do, and it is very, very difficult. What makes a good network? Because obviously there are areas where networks are really thriving and making a massive difference, but there's other places where people find it a real drag on their time and they don't see the benefits of it at all. So what do you think the benefits of being in a network are?
The networks, in my experience, that perform well have a shared purpose. They have a shared direction. They are all on the same page. There is a willingness to do it. There's willingness and there's compromise. There isn't the constant conflict of, I think that person's got more than me, or why is that person doing that, or why was I not included? Decisions can be made because they trust each other. If somebody can't be there, it's not like, oh, we can't have the meeting now. So I think that trust and shared purpose is so, so important. And I always say to people, you can absolutely have a network without a shared purpose, but it's really hard and really quite stressful and quite upsetting in some respects, because people are trying to move forward, but move forward in different directions. That's what I have seen. And I must admit, I underestimated it. I think when I very first started, I was the manager. It's like, this is what the DES said. And, like, we're going to do what the DES says. And they were just looked at me and were just like, we don't care what the DES says. Like, I've changed my approach and really want to understand what is it like for practices and how can we make the best of this? How can we use primary care network resources to support practices moving forward?
So when you're talking about a shared purpose, what kinds of things would a shared purpose be? What should they be looking to drive forward on?
I worked in Cranbrook Primary Care Network for quite a while, and we tried to have sessions on, like, shared purpose. And what kind of materialised is, in every meeting, the main objections were around, I thought we were working together to increase capacity. I've got more work. I thought this role was going to help us. And they kept repeating that. And I just kind of wrote that down. I was like, okay, so if we want more harmony in this network, when we introduce a role or a service or an idea, are we giving more people more work, or are we reducing capacity? And it can just literally be like that. Like, listen to the objections around why people don't want to do something. And if that is shared, there's your shared purpose. And I think it's maybe a different way of thinking about it. I think the more textbook way would be like, what's in it for me? What's in it for the practice? And what's in it for the patients? Sometimes that feels artificial, because you will get a shared purpose. Most, it's like right care, first time, like happy workforce. That's what we want. But in reality, sometimes it's something is stopping that. They do want that, but there is a deeper layer of history and politics stopping that. And sometimes using the negative and turning that into a positive can be helpful in building, why are we here? Like, we want to go home at a reasonable time, or we want to make sure like we are all included. So it can just be as simple as that.
I think that's one of the real complaints that I've heard from GPs about primary care networks and actually other people, is that it does increase workload. And that's, obviously a lot of GPs think that the reason networks were set up was to try and take workload off practices, really.
It's like when you move house, that is a lot of work. Get unexpected costs, a bit stressful. And even once you've moved, you might have to decorate, like room by room, and it takes a long time. So that additional work is an investment in the future. Nobody can say, I did a change, I implemented a strategic change overnight and it instantly saved me time. It's about investing in the future. This is a long-term play. There may be small wins, absolutely, and you need those to keep going. But I think that the changes that we're trying to create do take a long time. And I think that's where you need a team. You need people, different people to step forward and also appreciate the conflict. Like, we don't want conflict, but when you kind of take a step back and you can think, okay, I can see, like, it's stressful. There isn't enough money. And when you can kind of step back and not be so emotional about it, just take a breather, like, let's try to diffuse a situation and just move slowly, because it's not going to happen overnight. And if you try to push people, that's not going to help. But alternatively, it's not going to help if we just complain about it.
Do you think policymakers, people in general, do you think they've expected too much from primary care networks too quickly? Because obviously it takes a long time to build up, like you say now, and it takes a long time to develop relationships as well if you've never worked together before.
And I also think probably networks expect too much of themselves. And I suppose this goes back to the support. Primary care networks like a business arrangement. It's like a partnership, like a private sector. You'd like do you due diligence, like you'd really get to know people. Some business partners have coaches from the outset because they know conflict is going to happen. But primary care networks were not. They were just kind of chucked into this arranged marriage, given 6 figures. They just really underestimated what the ask was. It's not enough just because people are neighbours. It doesn't always make sense for them to work together. But from a patient's perspective, I'm in Whitstable in Kent. The care is phenomenal.
We're obviously a month or so into a new GP contract. Obviously there's massive concerns about the funding uplift for practices. It falls very far short of what they actually need. Many practices are quite worried about what's going to happen over the next year or so. What impact do you think all of this is going to have on primary care networks?
I think that the top best performing networks will continue to thrive. I think they've got more freedom and flexibility. They're thinking innovatively. They're working with beyond their practice, and they're in a situation where they've looked at their general practice finances and can think, okay, how can we best utilize the finances from a primary care network perspective to continue us? Don't get me wrong, it's still going to be challenging, but I do think I speak to some networks and they're like, we're okay. And then I think, it is going to be really tough. And I think we're seeing it now that those networks are they want to devolve as much money from the primary care network into general practice on an individual basis. The behaviours that brings up is quite hard. I say they just want their bit, but I'm not saying it in a naive or negative way. I get it. Like if you run a business and you feel like you're not going to be financially sustainable, or like your income has dramatically dropped and your staffing costs are rising, that's stressful. So they'll be looking to the primary care network to say, okay, can we not just divvy some things up and I'll take that piece? And I think it will make some networks quite unstable. The R's roles and the collaborative work that they've worked really hard to build, even though they think they've not made any progress, they probably have made significant progress, but it's still going through, like bumpy times. Will start to unravel, which will be really, really sad. and they will look to, lots of networks are, not lots, but I do know of networks, like splitting up. And that's not always a bad thing, because if you believe that you can create a network with a positive working culture and organise yourself differently, that is best for you and your sanity and the patients. We need solid general practices in order for collaborative working. You can't put others first if you need to put your own mask on first in order to be able to work with other people.
It's inevitable, isn't it? If you're a GP partner and you're worried about the financial viability of your business, you're not going to have any time or headspace to start thinking about networks and stuff. You're going to be more focused on the immediate priority of the practice.
That's true. You look at your own organisation, but then you've got your primary care network resource and you've got the primary care network mandate. And it's like, okay, how can we make this work? What is working? What makes sense to be able to deliver? Not so much in my general practice anymore. That doesn't, it's not financially viable. It doesn't make sense. It's maybe not be best for patients. What we could use primary care network resource to have a hub level social prescribing service or mental health service, or a hub level looking at our structured medication reviews versus every practice doing it differently and taking, like 1 hour of one person, 2 hours of another person. There is a way. It's not all doom and gloom, because there are lots of networks making it work. Primary care is good at sharing, actually. I think we're really good at sharing the good and the bad. And they like sharing because obviously they're doing good stuff. It's not just to share the finished product, is to really share how they got there and the finances. I don't see many presentations actually share, this is the financial impact. This is the money we've saved. This is the money all we've made. We don't see that. And I think that would be very interesting and very, very helpful.
You've mentioned the ARRS and the additional roles. I just wanted to ask you some questions about that, because obviously there's loads of problems really that are sort of starting to emerge. Obviously, the ARS is one of the biggest bits of funding that primary care networks get. And on the one hand, it's been a really big success. There's 26,000 new people working in primary care now, probably more than that. But we have got to this position where there's a lot of GPs struggling to find work. There's some real concerns about the registrars that are due to CCT this August about whether there's going to be jobs for them, because practices basically can't afford to hire them. There is a view amongst quite a few GPs I spoke to that all the extra money pumped into primary care has gone into the wrong place, i.e. PCNs and not into core funding. What's your view about the ARRS? I mean, do you think it's been a good thing?
I do think it's been a good thing, but there's understandably unintended negative consequences. There's only so much money. But my understanding of the additional roles is that we don't have enough GPs. And actually, could we start to promote a different model of care? Because lots of people go to the GP, but they don't need to see the general practitioner. They don't always need to see that person. Can we not introduce other roles? If I've hurt my back, do I need to see the GP, or could I see a physio? Or if I have hit a tough period in my life, do I need to see the GP and talk to that person? Or could I see a social prescribing link worker? There are pros, and there are lots of people doing amazing things. I mean, I spoke to Bernardo's and they co-produced a social prescribing service for young people with 5 primary care networks. And there are networks that have, one's got like the Hive project, and they've got an allotment, and they're getting people more active. A GP by themselves wouldn't have necessarily been able to have done that. Some practices absolutely. So I do think there's absolutely is good. We have to do something different, and they're trying to do it differently. My youngest has got type 1 diabetes. I go to the doctor for her regular appointments, but I get a lot of peer support from other families. We see a dietitian. We get a lot of support from the school. We get a lot of support from tech companies. So having that wider network of support stops me from going to the GP or the hospital consultant. I don't need to see those people all the time.
Having all these extra healthcare professionals and having a multidisciplinary team, it is obviously a benefit, but it's perhaps not a benefit if it's at the expense of having enough GPs. And obviously, if core funding had increased as well, at least in line with inflation, then practices wouldn't be in the position they are at the minute about having to think about cutting back on the number of sessions that they run with GPs. Maybe it shouldn't be an either or, it should have been that and that, having the ARRS and more money for core funding.
And I think that ours roles are caught in the crossfire. And I think the mentality, one thing that I felt really passionate about and still do is that, like if you don't use it, you lose it. So at times of the year, that message last year really came out loud and clear. So people made the wrong hiring decisions. At one point, NHS England were going to take the baseline of staff and that was going to roll forward. So you wanted to maximise it. So max that out, recruit, like higher services. And then those roles, because of the context they work within, a lot of them were not met with a positive response. It wasn't really clear in what they wanted to do. There wasn't clinical supervision, there wasn't support, and they feel like they've done something wrong all the time just through their pure existence. They didn't recruit themselves. They were hired, but into a very, very difficult environment.
The job of becoming a GP is becoming harder and harder. And I think one of the problems is there's very little recognition of that. We only saw not that long ago a former health minister saying that GPs, what they do is really simple. And so there's a real lack of understanding, I think, about the kind of challenges that from people on high, the challenges GPs are dealing with every day.
One of the messages I would always say to new primary care managers, everybody thinks everything is about them. But in a primary care network, if you don't understand what it's like to be a GP, or you don't talk to them, you don't understand their challenges, that's where conflict happens. It's hard to find the time when you don't feel like you've got the time. But if you don't find the time to talk, you're never going to create a positive working atmosphere. And for a GP to just share, this is a typical week, this is what happened yesterday, this is the financial impact of the network, this is what it feels like when we come to a meeting and we're having the same conversation, for 6 months and we can't make a decision. That makes me want to disengage, like I'm losing the will to live. It's like any relationship, isn't it? When you make the effort to understand somebody else's point of view, you don't have to agree with it. It's okay to think differently. That is key, that understanding. And the more understanding that we have, we'll be able to move forward. We want to move forward in different directions. That's okay. But we need to communicate that, clearly, kindly, and respectfully. It doesn't always have to be in conflict.
The BMA's position is that all the money in primary care networks should be moved into core funding. Do you think PCNs are here to stay? Do you think that money's ever likely to move out of primary care networks into core funding?
I think they are here to stay. I think so much investment has gone into it. I hope that we can make it work. It's really sad. And I think I've worked with, over 120 networks. People say to me, I'm leaving, or I want to leave, or I hate it. And that's everybody in the network. Practice managers hate it. CDs are always threatening to quit. The manager hates it. The pharmacists don't enjoy it. Some of them don't enjoy it. It can be a really tough environment. And sometimes I just think, but we're all people. We all just want to do a good job. And I hope that networks can find a model where it does make sense to do things individually, and it absolutely makes sense to do things more collaboratively. It doesn't make sense for 7 practices to do the same thing if it's not financially viable for them. Why do we not just create a different sort of model, use our PCN resources, use other parts of the community? Let's ask our patients and see what we can do differently. But I do think for the foreseeable future, we're here to stay, but it'll be interesting to see what shakes out after the election. It's not all bad. I want to believe that it's not all bad. We will always have general practice. We'll always have our local general practice surgery. They are part of the community. We are part of that strategic change. And in 10 years' time, or when lots of people are retired and they look back, they'll think, it was our blood, sweat and tears that helped get us there. I think it's a big change, and I think we have to believe it will get better. Otherwise, what's the point,
There's such new organisations. Well, they're not even proper organisations to a certain extent. And you can't expect them to be doing everything and making everything okay after just 5 years. It's such a short time.
Yeah.
The last 2 years, we've had integrated care boards. I mean, obviously, that's been massive upheaval. Has it changed anything for primary care networks, those changes? Has it made it easier? Has it made it harder?
It's still very, very early days, but I think to the average general practice and primary care network or typical, the ICB is an annoyance, like they're just the emails that tell, like, can you do this? Can you fill this in? Can I have it now? They're just a bit like Big Brother in some respects, but some ICBs, I think they've supported networks in regards to, like providing development support and structure and bringing them together. So you've got like networks of networks, you've got a board of 10 networks in the ICB coming together. I think they're in engagement. And I think I did speak to another CD where their ICB was creating their primary care strategy. And there was tension there. There was tension in the ICB just not really getting the level of engagement. If you really want primary care, if you really want general practices to be on board with this strategy, let them help you shape it. Whereas that wasn't the mentality. So every area runs very, very differently.
The GP contract, it did bring some small changes for networks this year. I mean, NHS England says it's supposed to simplify things for networks, but are there any changes in there that will make a difference, do you think, make things easier? Or is it all just a bit tinkering around the edges?
Yeah, it's just tinkering. I mean, they can have enhanced nurses, which is just good. That's different.
Yeah.
I think it's same business as usual and I think to look at that in a positive way. There's no big changes. So that's a relief. You're not being asked to do masses more. So that is good. I think there's less accountability in a good way. Said, I've trusted you. I think the messages I've heard is that primary care networks have said to NHS England, I want less bureaucracy, chasing these targets that some of them are just impossible to, like ever achieve. And some of it's just business as usual. And they've gone, okay, you do what you think is best, but can you just organise yourself a little bit better? I think that they are listening.
You've talked a bit as we've gone through all this about the fact that there are lots of benefits of being in a network and some of the challenges they face. But, if there's anyone listening to this, like particularly like GPs or practice managers, and they don't necessarily feel that they're getting what they could do from their network, what advice would you give them? What advice would you give them to help them get the most for them personally and for their practice from their network? What's the best way to go about that?
I think it's about going back to basics. Use your next primary care network meeting, change the agenda, get all of the, day-to-day operational stuff off because it's just the same conversation over and over and over again. And I would just really think about moving forwards. What does it make sense for us to do individually and what can we do collaboratively? And I think also to share a little bit of this is what life is like in our practice at the moment. I think that would be a really good start. My plea is just be kind. We don't all have to be best friends and we don't all have to agree. It's just to be kind and just really think about, okay, we're in this situation. Do we want to be part of the network? Yes or no? And if we are going to be part of it, what can we do with what we've got? It might just be business as usual. It might be, okay, well, let's just have more meetings where we don't have this agenda where, there's 15 points in an hour. It may just be, let's just spend a little bit of more quality time, just really thinking about what are we going to do or what are our strategic priorities. I think it's really just about going back to basics. When I very first started, as I said, it was all about the DES. Now I'm fixated on how can we make the primary care network work for practices. So I want to understand my general practices and then go, okay, how can we utilize the resources that the network has to make sure the practices are solid? And that means sometimes doing things individually, but never losing that element of collaboration. We're still a network, we're still a group of practices coming together. And when we look at the finances, it absolutely makes sense to cut some things, streamline it and fund it across the network.
That's actually a really positive place to probably end things there.
It's not all bad.
Thank you very much, Tara. Thanks for coming on the podcast.
Thank you. Thank you for having me.
Well, that's it for this week. Thanks for listening, and thanks so much to Tara for taking the time to talk with me this week. I'll be back next week with Nick and Kimberly for our regular news review. In the meantime, you can keep up to date with all the latest news affecting primary care, including our coverage of the UK Local Medical Committees Conference this week, on our website at GPonline.com.